The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another edition of Inside JACC. And one of the issues that's attracted a lot of attention recently is international participation in clinical trials. And we have a very interesting and I think important paper in press in JACC that deals with this very issue. And this morning I have the opportunity to talk to the senior author, Dr. Venu Menon. And Dr. Menon is the director of the coronary care unit at the Cleveland Clinic. And in writing this manuscript, they reviewed clinical trials sponsored by the NIH on cardiovascular disease. And after doing a thorough search of the NIH records, they identified 25 trials, and 19 of these had international participation, a median participation of just under 10%, average about 15%. In fact, in clinical trials that dealt with coronary artery disease, the international participation was nearly 50%. Big clinical trials like the OAT trial, the occluded artery trial, and the STITCH trial. So, Dr. Menon, let me begin by raising a question. If international participation is this common in NIH trials, is it even more common in industrially sponsored trials?
It certainly is, Dr. DeMaria. I think over the last decade or so, there's been significant globalization of research around the world. And so what we see in the NIH trials certainly mirrors what we see in the global perspective in terms of clinical research.
Now, why is it that there is an increasing level of international participation in these important randomized clinical trials?
I think, it's a number of issues account for these findings. I think the first thing is over the years, we've developed a strong global network of investigators where we've been able to conduct these trials across continents and get data on clinical trials in multiple health scenarios. Our issues in terms of writing these papers was, given the size of the United States, we were completely supportive of conducting these trials internationally, but we felt that some of the reasons that compelled us to seek participants around the world might have been in terms of our performance, or rather our underperformance in being able to recruit significant number of patients in our own shores. And that's basically the premise that led us to explore and report on these findings.
Yes, I was quite taken with your comment that the United States, with a population of over 300 million people, were only able to enroll about 200 patients in the STITCH trial, while Poland, with a population of just 38 million, was able to enroll 288. Does that say something about the clinical research environment in the United States?
I think it really does, and I think that was the reason why we thought we had this manuscript come out in press, because I think the powers that be at the various levels really need to get into the nitty-gritty as to why this phenomenon has occurred. Has it occurred because our patients are not getting themselves obliged to randomize into these trials? Is it because, despite having so many acute hospitals around the country, our commitment to these trials falls short? Or is it just because we don't have the clinical infrastructure anymore, given the regulatory concerns and other concerns that have been raised in other manuscripts, that we've become completely inefficient in our ability to recruit patients, that we ourselves, using our apex research body, have identified questions that we think are of national importance and are yet unable to enroll our own patients? The key thing here is that the reason why we do clinical trials is to get some quantitative assessment of what the benefits of a therapy are when we apply them to our patients. And so if we don't get patients in our own healthcare environment, in their own background medical therapy, then the translation of these results into clinical practice, which I believe is the purpose of doing this study in the first place, tends to fall short. And so we hope that drawing attention to this will have the folks who have the ability to change this environment at the patient level, at the physician level, at the institution level, and at national and federal levels, this brings up some attention, and that appropriate changes are then made.
Yes, well, clearly there are some benefits to involving the international community in research. There are some real issues as to whether the results in patients that are outside the United States are transferable readily to the United States and vice versa. It raises important issues, and this has clearly been shown in the analysis of subgroups in several recent clinical trials. A very important issue, and one we're very glad that you brought up to the forefront. For Inside JACC, I'm Tony DeMaria.